Rendina and Dr. Cooper, thank you very much. It's my honor to be invited to speak at this meeting and discuss for a few moments the application of lung transplantation for patients with emphysema. What I would like to just say from the outset that lung transplantation is alive and well, although it's being less frequently employed for patients with emphysema, at least in the United States. It's interesting to reflect on the first human lung transplantation attempt that was performed by Dr. James Hardy in Mississippi in 1963. It's even more interesting to think about the scenario of this transplant procedure. The recipient was a patient with severe chronic obstructive lung disease who happened to have a left hilar cancer, and this novel cancer operation was conducted utilizing a donor which was a non-heart-beating donor, actually an uncontrolled donor by today's definition, a patient who had suffered a myocardial infarction. So quite an unusual scenario for transplantation. We've heard some terrific talks on lung volume reduction surgery, and this is a very old slide from Joel, which kind of depicted our algorithm of patient selection for volume reduction or transplant. And I don't think this has, at least in our own center, has changed greatly over the years. We still utilize lung volume reduction surgery whenever we can, but for patients who have homogeneous disease with FEV1 less than 20, particularly patients of older age, we generally recommend transplant as an option. And of course, there's two options for the application of lung transplantation for patients with emphysema. There's the single lung option, which interestingly, until the report from the French group in 1989, single lung was thought to be not an option for patients with emphysema because of the perceived problem of ventilation perfusion mismatching. But Mal and his colleagues demonstrated quite nicely that single lung transplant would work effectively, and until recently, single lung transplant for emphysema was probably the most common lung transplant operation performed worldwide. You can see this typical example of a preoperative distended chest and the postoperative results showing a shift of the mediastinum to the right side of the allograft, demonstrating nice lung volume reduction effect, if you like, with a healthy graft functioning well on the right side. And the bilateral approach, which actually we favor for reasons that I'll mention shortly, produces excellent results with immediate restoration of chest contour and excellent functional results over time. I recognize the controversy of single lung and bilateral lung transplant and the arguments in favor of each, but our own preference is to utilize the bilateral option, and I'll demonstrate why shortly. Most of these operations can be conducted through bilateral anterolateral thoracotomies. We no longer divide the sternum in emphysema patients, as we have excellent access to the entire thorax through a small anterolateral incision. And actually for a unilateral operation, this provides very nice exposure as well. If we look at the indications for lung transplantation for single lung transplant worldwide, this is International Society for Heart and Lung Transplant Registry data. It's a couple of years old, but it hasn't changed greatly. We see that the commonest indication for single lung transplant worldwide is emphysema, representing more than half of the transplant procedures performed. Whereas for bilateral transplant, emphysema represents a less frequent application, although if you look at the combination of alpha-1 and COPD, it accounts for about 35% of bilateral transplants performed worldwide. If we look at survival for patients in the international registry, large numbers of patients, and I'll show you a little more detailed analysis of this subsequently, but you can see that the bilateral patients do have a superior long-term survival. Now this is colored somewhat by the poorer long-term survival by age, and this is reflected in this survival curve by diagnostic groups. So if we look at this patient, the patient group of transplant indications, the pulmonary fibrosis over time has the poorest long-term survival, and I think in large part that's because patients having transplant for IPF are typically older patients, as are patients with emphysema, who you can see have a similar poorer long-term survival, whereas the younger patients with cystic fibrosis and other indications generally have better long-term survival. In our own program, we did our 1,000th transplant towards the end of the year. You can see that the vast majority of these operations were primary transplant. Until recently, retransplant really was not much of an option in the U.S. And the majority of these operations by far are bilateral transplants. Overall, our 20-year experience, about half of the patients that we transplanted were suffering either from COPD or alpha-1 antitrypsin deficiency, so 50% of the overall transplants for obstructive lung disease. And that ratio has significantly changed in recent years, as you can see from this bar graph here demonstrating the transplant indications by year. COPD, the light blue on the bottom, represented well over half of the transplants that we did 10 years ago, and in the last couple of years that line has dropped dramatically as a result of the new allocation score that we're utilizing in the U.S., and I'll mention a word or two about that later. Actually, our current data shows an even steeper fall in the number of transplants performed for emphysema. If we looked at the data regarding survival for patients having COPD or alpha-1 as a diagnosis, despite the fact that the alpha-1 patients are a younger group of patients, there does not appear to be much difference in long-term survival in these groups. However, there's a definite separation of these curves when one looks at bilateral versus single lung recipients. This is data from an earlier paper by Steve Cassavy when he was working in our group. Also, Steve noticed a significant difference in the diagnosis of bronchiolitis obliterans syndrome or chronic graft dysfunction among patients having bilateral grafts in comparison to their single lung counterparts. If we look at a more recent analysis of our data for those patients with emphysema, a significantly greater number of patients having bilateral transplants with much better long-term survival than in the single lung group. It was at one point thought that the survival for patients having transplant for emphysema was not much greater than the survival of those patients on the waiting list without a transplant. That was a paper that was published more than 10 years ago utilizing UNOS data as a measure. However, if we look at the International Society of Heart and Lung Transplant data, we can observe some different findings. This demonstrates a couple of interesting things. The very much more widespread use of single lung transplant as an option in the early and mid-90s, and a steady increase in the last decade in the application of bilateral transplant for patients with emphysema worldwide. We also see the same survival benefit from bilateral transplant using these large numbers of patients from the ISHLT registry with actuarial survival much superior in the bilateral recipients. And actually, if I can go back to that one slide, if as part of this analysis that was published recently, they did a propensity scoring analysis, and bilateral transplant recipients still came out ahead. And this is an interesting bit of information as well. If we see the definite survival, if we look at hazard ratio for death, there's and no doubt a significant improvement in long-term survival for patients of younger age with COPD as a diagnosis. But once patients get into their older years, there's not such a great survival advantage, if any, in patients with emphysema. And that's something to seriously consider, particularly in view of the application of the lung allocation score. And for those of you not familiar, in the previous era, allocation of donor to recipients depended on recipient priority, which was determined entirely by recipient waiting time. Consideration of disease severity or likelihood of death on the waiting list had no relevance at all. And in 2005, a change was made which utilized an allocation score, LAS, and that score ranges from 0 to 100, and it's based entirely upon medical urgency, severity of disease, and taking into account things like FEV1, oxygen requirements, pulmonary hypertension, and disease diagnosis. And also taking into account expected benefit following transplant, so you can get an ever higher score, but you can get to a point as a recipient where when you begin to get renal failure or other problems, then your score drops because the likelihood of survival post-transplant also diminishes. So it's an interesting, complicated algorithm, but every patient is assigned a score. We had an opportunity to look at our experience over a period of a decade with patients prior to the LAS and post-LAS scoring system, looking at a variety of variables in that patient group. And as you can see, patients with COPD and alpha-1 antitrypsin deficiency have a very much lower score than patients with cystic fibrosis and IPF, particularly the patients with IPF having very high scores. Looked at in a different way, if we see the relatively low scores, and the interesting thing, not only are these COPD patients scored quite low, but the range is very narrow, whereas the IPF patients and the other patients, CF particularly, and also retransplants, interestingly, patients awaiting retransplantation tended to have a very high score as well. So what that does is it has a significant impact on the type of transplants we do. Here we see a significant number of patients with IPF or alpha-1 antitrypsin deficiency in the pre-score era in comparison to a much lower rate of those diagnoses in the post-era transplant series. And that has consequences because transplant for emphysema is a very straightforward procedure. It's technically easy to do, and the patients usually have a very smooth post-operative course in comparison to their more complicated colleagues. And that translates into longer ventilator time, longer time in the ICU, and longer time in hospital. Now, it hadn't we have not observed any particular impact on survival, but that perhaps just reflects a small number of patients in both groups. So in conclusion, I think despite low priority scores for these patients, there's no real reason to categorically exclude patients with COPD from consideration for transplantation. But since donor organs are such a limited resource, potential recipients with COPD, particularly older patients, must be selected very carefully. Thank you very much.
Thank you very much.